You ever have a patient where the approach to the treatment plan makes sense, the dosage is reasonable, they keep showing up, and the outcome is still not quite what you expected? Often enough, your rehab isn't failing because your plan is bad. It's failing because something important is driving the case from the outside. The exercise sheet and manual therapy provided, that's not the issue. So picture this, visit 4, let's say low back pain, but honestly, this could be shoulder, knee, neck, whatever. The patient's been coming consistently. You gave a reasonable plan. They're doing at least some of the homework, and pain is just basically unchanged. Function is barely improving, and now we're feeling the pressure to either progress their exercise harder, switch them up completely, or just assume that they're just plain non-compliant. But then you slow down and you ask a few better questions. Turns out they're sleeping 4 to 5 broken hours a night. They're terrified of flaring up at work. And the only time they try the HEP is at the very end of a completely exhausting day. This is going to change your case completely. So let's get right into it. One of the easiest traps in outpatient PT is assuming that if progress is lacking, then the missing answer just must be a better exercise, better manual therapy techniques, better progression, or better patient compliance, and perhaps that's right. Sometimes the program really does need work, but a lot of the time, the bigger problem is that we are over-auditing the exercise sheet and under-auditing the rest of the patient's life. That's what I mean by hidden factors. These are the inputs that don't always show up on the plan of care, but absolutely influence how the plan performs. We're thinking sleep, stress load, fear, work demands, home chaos, low confidence, unrealistic dosages, inconsistent daily activity, those boom-bust patterns, recovery capacity. A patient can have a decent program and still fail to improve if those inputs are bad enough. And when we miss that, we do something really common. We keep changing the visible plan while ignoring those invisible drivers. That is how good rehab plans start looking ineffective. Why does this matter so much? First, because it affects outcomes. If the real limiter is poor recovery, threat, overload, or behavior friction, then blindly progressing exercise may not help and can actually make the patient trust less about the process. Secondly, it affects your clinical reasoning. If you don't screen those hidden inputs, you may label the patient as difficult, inconsistent, or unmotivated, when the actual problem is that the rehab plan just doesn't fit their life. Third, it affects patient buy-in. Patients can feel when we're missing the real story. We're sensitive to those things, as we all are. If they're thinking, I'm barely sleeping, I'm stressed out of my mind, I'm scared to move, and this plan still expects perfect follow-through, they stop feeling understood, or in many cases, they're just going to feel plain defeated. And fourth, it affects how we document progress and communicate. A plateau looks very different when you understand whether the problem is tissue irritability, fear-driven, underloading, overload outside the clinic, or a habit system that was never realistic to begin with. This is the shift. Not every stalled case is a bad rehab program. Some stalled cases are a good rehab program just running inside some bad context. So what do we ask? Well, I'll tell you what, you don't need a 25-minute counseling session. You do not need to become a psychologist for the day. You do not need to turn every visit into a giant lifestyle interview. You just need to get better at asking a few clinically useful questions when progress isn't matching the plan. Here are the strongest few. First, what feels like the biggest thing getting in the way right now? So that question is going to be gold because it stops you from guessing. Sometimes the answer is pain. Sometimes it's schedule, fear. Sometimes it's fatigue. It might be that the program's actually too much for this person. Second, how has your sleep and recovery been this week? Not because sleep explains everything, it doesn't, but because awful sleep can change pain sensitivity, recovery, patience, energy, and follow-through. If you're sleeping terribly, you should at least know that before you interpret the week. Third, what happens on the days you flare up or skip the plan? Now you're looking for patterns. Is it work, childcare, perhaps long drives, fear, repeated boom bust activity, end of the day exhaustion? This gives you some leverage. Fourth, how confident do you feel doing this plan in real life and not in here in the clinic? So that question gets at some self-efficacy and friction. The patient may look fine in front of you and still have zero confidence doing the plan alone, especially if they are afraid of pain or don't know how hard to push. And fifth, are we asking you to do this at a time of day when you realistically have nothing left? That one matters more than some of you may think. A perfectly designed HEP done at the worst possible time is still a badly designed HEP. Notice what all of these questions do, though. They pull you away from assumptions and toward usable clinical information. So once you identify a hidden factor, what do you actually do next? Step one, match the plan to the limiter. If the limiter is fear, don't just hand them more reps. Tighten your education, reduce threat, simplify exposure, and make the win small and clear. If the limiter is poor recovery or high life load, stop pretending that you're programming for this ideal week. We got to shrink our dosages, reduce friction for the patient, and make the minimum effective version obvious for them to do. If their limiter is inconsistency from chaos, attach the plan to something stable, habit pairing, after coffee, brushing teeth, after getting home, but before sitting down, whatever actually fits their life. If the limiter is boom bust behavior, then your job is less about motivation, more about pacing this individual, expectation setting, and helping them stop turning good days into setback days. And if their limiter is unclear, symptom response, then you've got to define some rules for them. What amount of soreness is acceptable? What counts as a flare? When should they back off? Patients do better when the plan feels interpretable and they understand it. Step two, keep the plan narrow enough for them to win. This is where a lot of us can blow it. We see complexity, so we respond with more content, more exercise, more education, more instructions, more handouts. But overwhelmed patients do not need more impressive plans. They need a more executable one. Give them the version they can actually complete. Step three, say the hidden factor out loud in a useful way. You can literally say, I don't think this is just an exercise problem. I think your recovery load and the timing of the plan are making follow through harder than it needs to be. So let's adjust that. That kind of statement builds alliance because it shows you're not just blaming them or blindly recycling the same prescription. So now let's talk about documentation, because this is where good reasoning either gets captured or it just simply disappears. If progress is stalled, document the hidden inputs like they matter, because guess what they do? That might sound something along the lines of persistent symptom irritability and limited functional change if you're influenced by high external workload, poor sleep quality, fear of symptom provocation, and inconsistent home program execution related to schedule friction. HEP modified to reduce burden, improve clarity, and increase feasibility. Provided education on symptom response expectations and graded progression. That's a much stronger story than, let's say, patient not compliant with HEP. For follow-up, track 1 or 2 relevant variables, not 10. Pick what actually matches the case. Maybe symptom irritability, confidence with movement, number of HEP completions for the week, sleep quality, flare frequency, or response to work days versus off days. Then revisit it simply. What went better this week? What still got in the way? Did the smaller version feel more feasible? Did the new timing help? You're not just tracking pain, you're tracking whether the context is becoming more favorable for rehab to work. That is a more sophisticated way to manage a case. So here's the takeaway. When rehab is underperforming, do not automatically assume that the answer is better exercise selection or harder progressions. Sometimes the real issue is a hidden input the plan was never built around. Again, sleep, stress, fear, recovery capacity, activity spikes, poor timing, low confidence, home life friction. These are not details to be dismissed or just simply glossed over. They are relevant parts of the case. And your job is not to solve every problem in a person's life. Your job is to identify the factors that are clinically relevant to rehab, speak to them clearly, and adjust the plan so it has a real chance of it succeeding in the world the patient actually lives in. That's how you're going to stop calling people non-compliant when the plan was just never truly workable for them. That's how you protect alliance. That's how you make your reasoning look sharper, because it actually is sharper. If you want to expand your scope as a PT, this is part of it. Not abandoning exercise or anything, not replacing rehab with a vague wellness talk here, just getting better at seeing the full set of inputs that determine whether rehab works. If this episode hit home, share with a PT who's been stuck blaming the program for a case that might actually be a context problem. And if you're building a practice that goes beyond exercises and manual therapy alone, stick with me, because that's exactly where this is going.